All right, if you're a pathology trainee, you definitely know this feeling. A CNS tumor case lands on your desk, and yeah, it can be a little intimidating. So today we're going to demystify the whole process. We'll take a really practical tour through the CAP protocol for brain and spinal cord tumors. Think of it as your roadmap to getting it right every single time.
I mean, this is really the big question, isn't it? Brain tumors are just so incredibly diverse. So how do we make sure that a pathologist in one lab is communicating the same essential, clinically useful information as a pathologist, halfway across the country? Well, that's the exact problem these standardized protocols are built to solve.
So here's our game plan. We're going to walk through this protocol section by section, just like you would with a real case. We'll start with the protocol itself, then talk about setting the clinical scene, why location is everything, then dive into the modern integrated diagnosis, and finally, how to pull it all together in the final report.
Okay, let's start with the tool itself. The best way to think about the CAP protocol is as your blueprint. It gives you the structure you need to build a complete and accurate diagnostic report every single time. No guesswork involved.
And it's so important to remember, this is not just about ticking boxes. It's a critical communication tool. The whole point is to make sure that every key piece of data, the stuff neurosurgeons and oncologists really need for patient care, is captured and reported in the same way every time. It's basically our safety net to guarantee nothing critical gets missed. Now, it's also super useful to know what this protocol doesn't cover. It's specifically for primary CNS tumors. So if your case turns out to be a lymphoma, a primary bone tumor, a metastasis from somewhere else, or an MPNST, you're going to need a different protocol. Knowing the scope is always step one.
All right, next up, setting the clinical scene. Because let's be real, before you even put a slide on the microscope stage, you have to understand the context. A diagnosis never happens in a vacuum. It always starts with the patient's story.
And probably the most critical piece of that story is the history of prior therapy. There's a reason this is the very first clinical data point listed in the protocol. It can totally change what you're seeing under the microscope. And here's why. As the protocol notes, treatment can create huge diagnostic challenges. Think about it. Radiation and chemo are designed to kill tumor cells, right? Well, the after effects, like inflammation and cell death, can look exactly like a tumor coming back. Without knowing that treatment history, it's a diagnostic trap just waiting for you.
So what are you looking for? The protocol gives you a cheat sheet. You've got to check the clinical notes for any mention of chemotherapy, radiation, steroids, or even preoperative embolization, which you see a lot with tumors like meningiomas.
Let's zoom in on corticosteroids for a second, because this is a fantastic, high-yield example. In cases like primary CNS lymphoma, giving a patient steroids before a biopsy can literally make the tumor cells just melt away. You could get a slide that's full of cleanup cells, but hardly any tumor left. If you didn't know about that steroid treatment, you could be seriously misled.
So alongside that treatment history, your other essential piece of context is the neuroimaging. Seriously, think of the MRI or CT scan as your co-pilot for the case. You should never be flying blind.
The protocol really hammers this point home. Your diagnosis under the microscope has to make sense with what the imaging shows. If the scan shows a big, brightly enhancing lesion, but your slide looks almost normal, well, that's a major red flag you have to figure out. It just goes to show you, pathology is a team sport.
Okay, so we've got the clinical scene set. Now let's turn to the specimen itself. In neuropathology, that old real estate mantra is absolutely true. It is all about location, location, location. Where a tumor starts can basically be its destiny. And the reason this matters so much is that your differential diagnosis completely changes based on the tumor's site. A mass in the cerebellum of a kid points you in a totally different direction than one in the frontal lobe of an adult. Documenting that precise location is one of the most powerful clues you have. The protocol gives you this great detailed checklist of sites to think about. You're constantly asking, are we in the brain tissue itself, like a cerebral lobe? Or is this coming from the coverings, like the dura? Is it in the brainstem or the spinal cord? Getting this specific is absolutely key. Okay, let's get to the heart of the modern neuropathology report, the integrated diagnosis. This is a massive shift in how we classify CNS tumors, all based on that 2021 WHO update. This is the new gold standard. For decades, a diagnosis was pretty much based on what a tumor looked like under the microscope, its histology. But that's just not the whole story anymore. Now, as the protocol says, molecular information is literally integrated into the diagnosis itself. We've moved beyond just what it looks like to understanding its fundamental genetic drivers. So, how do you think about this? It really just boils down to two fundamental pillars. First, you still have the histologic classification. What does it look like? Is it an astrocytoma, an oligodryglioma? But then you combine that with the second pillar, its molecular profile. What are its key mutations or genetic changes? And this table just illustrates it perfectly. Look at the adult type diffuse gliomas. If you have a tumor that looks like an astrocytoma and it has an IDH mutation, your integrated diagnosis is astrocytoma, IDH mutant. Simple as that. If it looks like an oligo and has both an IDH mutation and a 1p19q codeletion, that's your diagnosis. And this is critical. A tumor can only be called glioblastoma, IDH wild type, if it lacks an IDH mutation. See? The molecular data isn't just extra info, it actually defines what the tumor is.
All right, we're in the home stretch. We've gathered our clinical history, we know the location, and we have our histologic and molecular data. Now for that final, crucial step, putting it all together into a clear, complete, and coherent report.
Part of this final synthesis is assigning a CNS WHO grade. This is basically a shorthand for the tumor's biological aggressiveness. It ranges from grade 1 for the most slow-growing lesions, all the way up to grade 4 for the most malignant ones. And this grade is directly tied to the specific integrated diagnosis you just made. So how do you present all this information? The protocol recommends this really elegant, layered format. You lead with the single most important line, the final integrated diagnosis. Then you build on it with the histology, the WHO grade, and the molecular data that got you there. It's just a logical flow that tells the whole story at a glance.
And that kind of leads us to a final thought. This field is moving so incredibly fast. I mean, molecular data has completely revolutionized how we classify CNS tumors in just the last few years. As our tools get even faster and more powerful, what comes next? It's a great reminder that mastering this protocol isn't just about getting your cases right today, it's about building the foundation for the future of neuropathology.